From Redfield Medical Direction, this is Lynn Nguyen, Associate Medical Director, and this is your June 2025 Protocol Review. As we're headed into the thick of summer, we can inevitably anticipate an increase in drownings. These are some of the most time-critical and emotionally challenging calls we face in the field. Every year, there are about one drowning-related death per 100,000 people nationwide. Florida has almost double that number. The interventions and care by EMS can really affect these numbers. Cardiac arrest in drowning cases are ultimately caused by a respiratory problem. In a submersion injury, the aspirated fluid washes out the surfactant in the lungs that help to keep the alveoli open. The destruction of the surfactant disrupts the alveolar capillary membrane, allowing fluid to shift into the lungs, resulting in non-cardiogenic pulmonary edema. This obviously leads to hypoxemia and eventually cardiac arrest. Even if ROSC is achieved, patients are likely to suffer permanent neurologic damage from the cerebral hypoxia. This is why successful resuscitation of a cardiac arrest secondary to submersion is rather uncommon. When managing the drowning patient, the first step is extrication of the patient from the body of water. Provider safety is paramount at this stage so that you don't add yourself to the number of patients. It's important to remove wet clothing and dry the patient. Efforts should be made to actively warm the patient externally to mitigate the evaporative heat loss from the submersion. This could be achieved with warm water packs, thermal blankets, warm oxygen, and warm IV infusions. The external warming may cause a paradoxical drop in temperature as it causes vasodilation in the peripheral vasculature. There is a lot of discussion to be had regarding the importance, if any, of cervical collar as a part of the bundle of care after a submersion injury. While it's not required in every case, it should definitely be considered in mechanisms like diving and trauma. The decision to apply cervical collar while in the water is very much a risk-benefit analysis, taking into consideration environments like a swimming pool versus swift water, where extrication should be prioritized before any spinal restriction device. Remember that submersion injuries are primarily a respiratory issue. This is why ventilation is a priority in these specific cases of cardiac arrest. Because of the pulmonary injury by the aspirated fluids, there's a low threshold to at least put on oxygen with nasal cannula. In the severe cases of cardiac arrest, rescue breaths have been shown to be associated with improved outcomes. In addition, due to the volume of fluid that is swallowed before aspiration occurs, you can almost always expect a component of nausea and vomiting, so ondansetron should be considered even if prophylactically. With the summer heat, we'll also need to be expecting more heat-related illnesses. These are a spectrum of processes ranging from heat cramps to heat stroke. The incidence of heat-related illnesses have been increasing over the years. Data reviewed by the CDC showed over 100,000 ED visits were heat-related in 2023, with over 90% of them unsurprisingly during the summer months. Of those, an approximated 2,325 cases resulted in death. Hyperthermia occurs when our body's thermoregulation systems are overloaded. Normally, our body tries to cool itself down by vasodilation to increase blood flow and sweating. Things start to literally fall apart when the heat overpowers our cooling mechanisms. At the molecular level, proteins and enzymes start to break down, leading to damage to major organs like the liver and kidneys. This triggers the immune system to start an inflammatory response, worsening the situation. If untreated, all of this can lead to organ failure, seizures, and death. The really young and really old have particularly hard times with thermoregulation. Young children and infants are still figuring it all out and naturally do not thermoregulate very well. On the other end of the spectrum, older adults tend to sweat less, and their chronic medications may have side effects that block their cooling mechanisms. The cornerstone of treatment of heat-related illnesses is cooling, which takes advantage of all methods of heat loss. This involves moving a patient to a cooler environment like the back of a rescue. Removal of excess clothing facilitates heat conduction. Evaporative cooling is dependent on the resources you have on hand and could be achieved by putting cold water over the patient or using a mist sprayer with fans. Rehydration is also important since dehydration can lead to electrolyte abnormalities, cardiac dysrhythmias, and kidney failure. Heat cramps are the mildest of the heat-related illnesses in which the patient experiences muscle cramping, usually in the legs and sometimes the abdomen. Their temperature will sometimes be normal to a little elevated. Passive cooling with oral fluids should be sufficient for these patients. You want to avoid aggressive rehydration because of the risk of overhydration precipitating hyponatremia, increasing morbidity and mortality through cerebral edema and encephalopathy. In cases of severe muscle cramping, you can try either Ativan or Versed IV push. Heat exhaustion occurs when patients start to show systemic symptoms like dizziness, fatigue, headache, nausea, or vomiting. These patients will have elevated temperatures and should be treated with active cooling measures by placing ice packs to the groin and armpits, in addition to IV fluids. Oral fluids should be encouraged if they're able to tolerate without vomiting. The most extreme of the heat-related illnesses is heat stroke. There's some overlap with heat exhaustion, with the differentiating features being neurologic signs of altered mental status. Classic cases of heat exhaustion involve dry, anhydrotic patients, but this is not a reliable sign since patients can still be diaphoretic with heat stroke. Cases of altered mental status with elevated temperatures should be treated as heat stroke. Cooling measures for these patients include evaporative cooling, which you can do by covering the patient with a water or saline-soaked sheet. Rapid cooling has been shown to improve morbidity and mortality. Cardiac monitoring and an EKG should be considered to screen for hyperkalemia that could be caused by severe muscle breakdown and renal failure. Seizures should be treated with benzos as per protocol. Among the old EMS practices that you might have heard of is the use of salt tablets for the treatment of heat-related illnesses. This is outdated and no longer recommended. Giving a patient salt tablets may worsen any ongoing GI issues. If resources are available, cold water immersion is the best treatment for heat stroke. If you're able to start this treatment, remember that the goal is not a normal body temperature, but rather a lower temperature of around 102 degrees Fahrenheit. The faster we recognize heat illnesses and start cooling, the better the outcome. And that's all we have for this episode. This has been a production of Redfield Medical Direction. This review was produced by me, Lin Win. Special thanks to Dr. Megan Markham for her tips and advice based on her own lecture on ED management of drownings. Our theme music is by Infraction. As always, reach out if you have any questions. See you next time.